All right, go ahead, Dr. Schroll.
Well, thank you. Christy's going to be assisting me with the slides. Next slide, please. So I thought we would talk today, an overview of palliative care, make sure people understand how to separate that from hospice, and talk about the study of dying in America and some of the implications for our work. And then we'll look at some of the key things that I'm thinking about when I'm doing
some of these we need to look on YouTube for the one they had a couple of weeks ago. Oh, the sound as well.
Mute yourself.
Are we all set? And talk about some of the things I'm thinking about when I'm doing a consult. So looking at the patient's capacity and their understanding of their diagnosis. And then we'll look at some specific conversation prompts, how to get these conversations kind of going, and talk a little bit about the paperwork that we often are filling out, advanced directives and upholst, and then some of my favorite resources for ongoing learning. Next slide. So palliative care is specialized care for people with serious illness. What I like to tell families and patients is at any age and any stage of serious illness. So when I am consulted on a younger patient, it's often something traumatic, an accident, an injury, a head trauma, or sometimes a paralysis. So some kind of life-changing diagnosis, although not necessarily a terminal diagnosis. The emphasis of our care is to individualize it, to look at symptom management needs. Our goal is to enhance quality of life and address the stress of illness. And when I'm thinking about the unit of care, I am thinking about the family. Serious illness impacts not just the patient, but the family, who often are participating in the care. They may be helping in decision-making, or they may be actually involved in providing care for the patient, getting them back and forth to appointments. So it can be life-changing, not just for patient, but for families too. So we engage in dialogues to get an understanding of who is this patient, what are their priorities, goals, how do they define quality of life, are there any limits to what would be okay for their care. We're talking about treating the whole patient. And to be clear, patients receiving palliative care can also be continuing to get active and curative therapies. So that might be chemo, radiation, they might be going to surgery. So they're still getting active management. Next slide. So when we think about palliative care, we think about primary palliative care. The way I would define that is care being offered on the front lines. So in the primary care office at the bedside, we are training folks to do some of those goals of care and quality of life discussions. We want to identify someone who can speak for that patient if they reach a point where they cannot make their own decisions, help getting things documented, and then some basic assessment and management skills, including comfort care and hospice management. Specialty palliative care is often a team that has taken advanced training. Palliative care is often provided in a interdisciplinary team-based manner. At Enloe, the way we operated was by consultation. So we would get a referral, usually driven by the physician, the primary physician, the hospitalist, or the surgeon on the case. And then our goal would be to collaborate with the primary team, make some recommendations in the care, but the daily management of the patient remained the responsibility of the primary team. We did not have a palliative care unit. Patients weren't transferred into our care, into our unit. You will see at larger medical centers that often there is actually a palliative care unit, and patients might be transferred and their care might then be taken over by the palliative care team. So these patients are usually more complex. We often try to, or at some point during the hospitalization, get a family meeting. COVID has made that more complicated. More of our, in the last year and a half, more of our consults were being done via video or phone, just because of the limits of people at the bedside and the limits of, early on it was because we were concerned about availability of protective gear. So we've had to make a lot of adjustments in the last year and a half to how we provide our care. Next, please. So we have an inpatient team run as a consultation service. The folks that we often see would be people who are recently diagnosed with some kind of life-changing, as I said earlier, that is sometimes people who've had some kind of traumas. Maybe they've had a new diagnosis of a cancer. They've recently had a heart attack. Another thing that I see a lot of, and I come to see this as chronic illness, is substance abuse. So when I have a young person, maybe it's methamphetamine, I'm seeing people in heart failure, sometimes as early as their 30s, often their 40s. Alcohol, I was seeing people with advanced liver disease in their 40s and 50s. So those are some of the things that we saw frequently. These are also some of our elderly people that might have a high score on the frailty screening. One of the recommendations coming from the trauma surgery specialty is that folks should have a palliative care consult prior to going to the OR if they have a high score on the frailty screening. We are consulted to help families who are having difficulty making care decisions, families in distress, patients who have a high burden of symptoms, those who we see often have had recurrent hospitalizations, or they're critically ill in our ICU and we're worried about their ability to recover. On the outpatient arena, we offer primary care services to a population of patients who are homebound and in need of primary care services. This is another broad spectrum of diagnoses, but not unusual if they have metastatic cancers, often advanced organ failure, patients who are frail and just not able to get out of the home, people who have failure to thrive and have had recurrent hospitalizations. Another way to kind of think about who is appropriate for a referral would be, would you be surprised if the patient were to die within the next year or so? That's just kind of gives you a little way of thinking about the population and their risk for demise. Next slide, please. Hospice care is palliative care for patients who have been identified with a terminal illness. By Medicare, 2 doctors have to be able to give an estimate of a prognosis of less than 6 months. I have found sometimes a prognosis to be some of the challenging, one of the more challenging things that we do, and particularly for people with neurological prognoses. Sometimes that could be stroke or dementia. I find sometimes how quickly that process might happen sometimes is a little bit harder. So again, these are rough estimates that we're making. And sometimes you will hear, oh, the patient graduated from hospice. And oftentimes that's because their medical situation stabilized. As an example, one of the things we see frequently with our population of patients with underlying dementia is if they did get COVID, they often had a loss of appetite and they started having that sort of failure to thrive picture. Some of these patients would come under hospice care and they might stabilize. I hesitate to say they don't get better, they aren't cured, but their decline is not as rapid as initially it appeared that it might be. And that's why you might hear situations of, oh, well, our loved one was already on hospice or they graduated from hospice. So sometimes that decline is not as rapid as it was initially appearing to be. The goal of hospice is an emphasis on management of symptoms over disease treatment or cure. Often they are at a point where they are not tolerating or the medical situation is not curable. This is a Medicare benefit. It emphasizes care at home with an interdisciplinary team of professionals. And that's one of the things I enjoy about working with hospice is that team, having that team support, bringing all the people to the table, getting their insights into the care. I emphasize at home because in the North State, other options are limited. We don't have a hospice house operating right now in the North State. The challenge with that is that families have to be prepared to do a lot of that day-to-day care. No one is moving in to provide that care for the patient. So the medical team will visit, and the number of times they visit in a week is individualized to the needs of that patient. But as far as administering medications regularly and toileting and bathing, that's often the support of the family. And that's a lot of work. I don't kid people about that when I'm talking about bringing a loved one home on hospice care. Alternatively, folks might be in assisted living environments or skilled nursing environments. And the goal is to avoid the back and forth to the hospital and the in and out of the ER. And I also tell folks when I am explaining hospice that we are usually, what we're planning is to allow for a natural death. That is the language that I usually use when I'm communicating with patients and families. Next slide.
Are they eligible for hospice care if they're at an assisted living facility or something like that?
Yes, people can get, if they have a terminal, if it appears they have a terminal illness, oftentimes maybe they've been hospitalized, and upon the evaluation in the hospital, they kind of reached that, they've crossed that road where it's time to start thinking about hospice. And then most assisted living facilities will take these patients with hospice care. One of the challenges that we run into actually is when the assisted living facility wants hospice, but the patient doesn't quite meet criteria. So the assisted facility might feel like, oh, they need a little more support than we can offer. We'd like to get hospice on board. But from the standpoint of the hospice, we have to be able to identify something terminal. And that sometimes is one of the challenges I see. The Institute of Medicine had a pretty comprehensive evaluation they call Dying in America. It was a 2-year study looking at what does end of life look like here in the US. And so a 21-member national committee with medical providers, but also others coming from the insurance industry, religious leaders, legal experts. And the bottom line was that it was really quite evident that we need a more comprehensive evaluation and care plan to address the needs of people at end of life. Next. So one of the concerns was that communication between providers and patients was deemed to be poor. Most people, when you ask them, will opt for quality of life over living longer, but few patients have actually talked to their providers or sometimes even their families about what these wishes are. We tend to have really strong feelings about the type of care that we want. Again, it's about getting that communicated to each other. Next slide. So recommendations that came out of this study was end-of-life care needs to be consistent with the patient's and family's values and goals. And we need to emphasize quality standards for communication and look at how we can improve advanced care planning that is evidence-based and measurable. Next. So why talking matters? Most people feel that it is important to have a plan to think in advance of what their priorities are for end of life, but only about 27% have actually done so. One of the things I hear all the time from patients is that they do not want to be a burden to their family, and they don't want to leave them with really difficult decisions that they have to make without the patient. But about 56% have not actually communicated what these priorities are. one of the hardest things that I saw when I was rounding, particularly in the ICU, was when the medical team would look at the loved ones, and we have a patient on the ventilator, maybe they're unresponsive, there's been a massive stroke, something that they may not recover from, and we would look to the family and say, well, what should we do now? And they were deer in the headlights. We have no idea. We never talked about it. I'm not sure what he would want. And I found that to be some of the highest burdens on families, is just that experience of really being at a loss as to how to respond. 80% of folks surveyed said if they were seriously ill, they would want to talk to their doctor about what their preferences were, but only 7% have actually done that. 82% say that it is important to have it in writing, but only 23% have folks have done that. Next. So we have a challenge, a large challenge in front of us, and that is in meeting the needs of those patients who are not quite eligible for hospice. Maybe the prognosis is unclear, or they want to continue with their disease treatment. This is a population that has a high utilization of the ER, 911, and recurrent hospitalizations. Next. So why is this so hard? Why do we avoid tough conversations? As coming from the perspective of providers, there's a fear of destroying hope. And there's also a fear of the strong emotions that we might bring about. Less than 10% of healthcare staff have had any formal training in how to share bad news. And this is very distressing for us, and also a potential cause for stress and burnout. However, the good news is that studies have demonstrated that communication skills can be taught and retained, and breaking bad news is recognized as a special skill that we can work at and get better at. Next. So when we anticipate that we need to have a difficult conversation, we want to prepare for that. Arrange to have a private, quiet place where we can sit down. I don't respond to my phone when I'm with families, having a family meeting or interviewing a patient. You want to remember to bring tissues, have tissues available, and sit down, make eye contact. When I was in my office, as an example, and I knew I had to go over biopsy results or tell someone that they had cancer, I often arrange for that to be the last appointment of the day, or maybe right before lunch, so that I would have a little bit of time. I could take as much time as I wanted with the family. And we need sometimes time to recover from the intensity of these kind of discussions. They recommend, if you are having a family meeting and you have other providers, so a lot of times in the hospital, I might have surgeons or neurology, or I might have the ICU physician. We kind of briefly huddle in advance. So I usually let them present their information, understanding that the other physicians might have to go. They might have to leave. They may have to get to the ER, do another admission, or maybe they're on their way to the OR. So they share their part. And then I help the families and patients understand what's been said, what they've been told. We also need to take the time sometimes just to allow for a little silence. And then it's also a good idea to have someone to help support you. So sometimes it's me, and I know my time is limited. And I might have someone who can move that conversation along, or I will offer some additional support with social work or the RN, or maybe there's a chaplain who can help the families with some of the emotions that they're feeling after our discussion. Next, please. So when you are working with surrogates, so the good example is we have an ICU patient, unresponsive on the ventilator. It's important that we always kind of come back to the patient. Tell me more about your partner, your husband, your loved one. If they could speak for themselves, what do you think they would want us to know? What would they tell us? Has any paperwork been prepared? What kind of conversations have already been had? So for example, I often would hear things along the lines of, oh, well, she felt this way because her mother was in a coma, and this is how she felt about that. This is what she told me would be important to her. So as an example, my mother happens to be a nurse, a 93-year-old retired nurse. And I think from the age of 12, she sort of started telling me what her priorities were for her care and what was going to be acceptable and what was not going to be acceptable. So that is a way of just, it's not unusual that people have had some kind of conversations based on observing someone else, or if they happen to work in the health field, they often have pretty strong feelings about some of the procedures that we do in medicine. Next. So, and one of the first things that I'm thinking about as I am engaging with a patient is I'm thinking about capacity. And capacity is more than just being alert and oriented. Capacity depends somewhat on what we are asking them. And so the first thing we need to see is how much do they actually understand about the medical situation, the risks and benefits of what has been proposed to them. So maybe it's surgery. Do they understand the implications? What that recovery might look like if they were to go ahead with the surgery. So I'm often asking the patient, tell me about the conversations you've had with the physicians. So, and sometimes they'll respond to me, well, didn't you read my file? But the purpose of that question wasn't about whether I understood, it's rather about whether they understand. And sometimes I'll tell them, I say, well, I just wanted to, make sure I understand what you took away from, what was the message that you got from the physicians. So often, because we are a consultative service, they have had maybe an oncologist, maybe a surgeon, the cardiologist has given them some information. What did they understand about that? And then are they able to clearly express a choice and give a clear decision about what it is they want? Do they understand the implication of, and do they appreciate how this applies to them? And are they able to give a reason, and can they weigh the pluses and minuses of these options that have been presented to them? So this is what we're looking at when we think about capacity. And one of the best references I found for capacity comes from the Up-to-Date. And this is where they have kind of split it up into the understanding, the expressing, the appreciation, and the reasoning. Next. And then one of the first things that we need to remember is to be prepared for and respond to those emotions. So I think for us coming from the medical world, we want to share information where we've got data, we have facts, we have figures, we have test results. We're passing those along. The patients are in another place where they might be much more emotional, and their ability to hear what we've said might be limited as a result. So one of the first things that we need to do before pushing forward with more data is stop and respond to the emotion, to where are they coming from at that moment. Next. So this is a little sticky I used to keep above my computer. People don't care what you know until they know you care. This just reminds me that our first obligation when we are working with patients is to develop that relationship, to create a relationship. And as a consultative service, sometimes it's limited. Our time to do that is somewhat limited. We have to go in and try to develop that relationship. And that's where one of the ways to do that is to make that response to that emotion, to let them know that you see or hear where they are at. Next. So sometimes that might be just allowing for silence. Another little sticky note, don't just do something, sit there. Be there and bear witness to that patient and where they're at. Before COVID, that sometimes would mean maybe holding their hand. I'm a fan of hugs if they allow it. Just listening, I think, is one of the most powerful things that we do for patients. And what I think is interesting, I've had staff tell me at times, well, I really didn't do anything. They just wanted to talk and I listened. And I always make sure to remind them that I think to be heard is such a powerful thing for folks. And that is, you did do something for them, something very powerful. And then what I'm doing is I'm kind of just reflecting back. So to clarify, and make sure I understand where they're coming from. So what I'm hearing is, or it sounds like, I use those expressions to make sure that we're on the same page. I can remember I had this older fellow, and he had, as I remember, I mean, I think he'd had a stroke. He had some severe kind of cardiac and advanced heart failure. And I sat down and I kind of started engaging, and I said something to the effects of, it sounds like you've really had a lot of challenges, or it's been, this has to be really hard to have all these issues. And he had, it was interesting because he had a very different take. He said, it's what makes me stronger. These challenges that I've faced have made me stronger. And he kind of expressed how he had a lot of faith and that was important to him. But it was good because what happened was, in my use of reflection, I heard more about how he thought about his situation. I heard more about what was important to him. And it really helped me to move forward with those understandings. Next. So some of the conversation prompts might include, how much information would you like? Sometimes it's helpful to really understand what they're ready to hear. How far can you go? What are they ready to hear? They might want to have someone with them when the oncologist comes, for example, or so just learning a little bit more about how they like to get information can be very helpful. If your health should worsen, what are your most important goals? Tell me about things that worry you or any fears you have. How much are you willing to go through for more time? And then one of my questions is, are there any limits? How far is too far? Are there things that you would want to avoid? People tend to have really strong feelings about, for example, mechanical ventilation, feeding tubes. Next line. I'm also, during the course of a consult, thinking about prognostic awareness. How much do they understand about their diagnosis? Are they able to integrate that into their disease and their life and their understanding? Once patients have a better understanding, then they can more effectively really weigh the burdens and benefits of treatment. And then we can have more meaningful dialogues with them about what they want, what their goals are, what those limits are. So the recommendations are that we start having some of these dialogues when people have a new and serious diagnosis. Next slide. Some of the other techniques that can be helpful, ask and tell, ask. So first we are assessing what is their understanding. So we're asking, tell me about your understanding of your cancer. Tell me about the consult you had with the oncologist. What have the doctors told you about this medical condition? What information would be most useful to you? And then tell them what you need to share. I wish I had better news, but I might be worried about, I'm worried that this cancer might be moving faster. Ask, and then ask again to see whether they, what they understood, what they heard. I want to make sure that we are both on the same page. Can you tell me what we just talked about? Next line. We also want to be a little bit careful about overdoing it or bringing out too much, maybe from our own personal experience. And so occasionally it might be helpful to develop a rapport to kind of say that maybe you've had a similar experience or a family member, but we want to be really careful about not dominating, and that we want to take it and we want to really keep the focus on the patient. Next slide. Another technique that I like is the hope, worry, or wish worry. I wish I had better news. I'm worried that your kidneys are failing. I'm worried about the possible need for dialysis. I hope that you are able to tolerate or respond to the treatment, but I'm worried about the side effects. I hope resuscitation would be successful. I'd be worried about the potential of harming you. Next line. This is just another sort of communication mnemonic. So setting up for a conversation, and then inquiring about what their perceptions and understanding of the situation is. Get an invitation to find out how much are they ready to hear. Next slide. And then provide the information that needs to be given. Sometimes maybe a warning shot so that they kind of see what's coming. I'm afraid. I have bad news. I'm worried about this or that. And then try to speak at their level and avoid the jargon. And that sometimes comes down to what I call reading the room, kind of trying to see what is the language that is used, what words do they, by listening to what they are saying, and then kind of, we do a lot of interpreting. I've had folks often tell me that, well, yeah, the surgeon was here, but sometimes they need a little bit of interpreting as to what was proposed. It's important too that folks understand that we will be there to help support, and that we are there to help also when the emotions, which can get sometimes quite intense. And what I tell my team is, we have to be prepared and kind of expect almost anything. That could be tears. Some people kind of just shut down. Some families might storm out because they're just not ready to hear. So we just have to be prepared for almost anything. Next. Other things that I like to hear directly when patients are able to share is what gives you strength, particularly when I have someone who has been facing illness for a long time. Often what I hear are things, it might be faith, but often it's also family. The other thing that I hear from people is that they often will continue treatments primarily because of family. They want to be there for something, for some event, for some holiday. Another thing that I found really interesting is a lot of times they do it for us. They really value that relationship with their physician, and they want to continue that relationship, and that might mean continuing oncological therapies or something along those lines. What abilities are so critical that you couldn't imagine living without them? And then one of the questions I often like to look at is, have you actually talked with your family about this? Again, because I've seen sometimes a major disconnect, and when the patients get sicker and can't tell us what they want, it's really hard on the families. And then another that I usually finish up with is there something I didn't ask that you want me to know? And I found this to be a really good opportunity for a person to kind of bring out that little nugget of information that isn't part of our standardized sort of interview. It might be a quality of life consideration. It might be some kind of care priority. People aren't used to hearing that kind of question though, so sometimes they are not really sure how to respond. Next. So these are some of the other conversation starters, and that might be, are there any limits to what is okay? Concerns about suffering or loss of control. And then again, I ask about have they talked to anyone about that? And then I will inquire about whether spiritual beliefs are an important part or an important consideration. And then another thought, particularly if we're talking about hospice, people have strong feelings about where they want to be when their time comes to an end. And for most folks, it is at home. Unfortunately, a lot of people still end up in our ICU and in the hospital. And that's why I like to talk, and I tell people that I like to talk about hospice before you're ready for hospice. And I often will do that. And I say, if there comes a time when you don't want to come back to the hospital, or you want to avoid that sort of back and forth and in and out of the ER, we can start talking about care at home, bringing care to you at home with that goal of trying to avoid being back in the hospital. Next. And then another challenge is how to bring up sensitive subjects. So the first thing I'm thinking about is, look, read the room. So who are the players in the room? What I'm watching for their facial expressions. I can remember one of my favorite professors when I was doing rounds at the VA. Before we could go in and start our exam, before we could put the stethoscope on the patient, he said, just stand at the edge of the bed. Stand at the end of the bed and look. What are you seeing? What is their engagement? What is the color of their skin? But this is particularly kind of assessing their affect, and are they making eye contact? And then, of course, I'm thinking about the other members of the family in the room and kind of observing their responses. And then respond to emotions. Make sure to reflect back. One of the ways that I find that I can kind of bring up delicate subjects is by saying, sometimes patients tell me. So as an example, sometimes patients tell me they don't want to continue with the dialysis or the chemotherapy or the radiation. And it's a way of saying, you're not alone. I've heard this before. It's not something to be ashamed of. It's a way of supporting them and just allowing them to kind of open up. Next. So some of the pitfalls to think about is starting too late or not at all in these conversations. So unfortunately, most of the conversations I have at the hospital are in a circumstance of crisis. Someone's just had some kind of something that brought them into the hospital. Sometimes it is sort of a recurrence of a chronic illness. Sometimes it's a new diagnosis. Frequently, we're often consulted because something major has occurred. And then expecting too much too soon. So it's not unusual when I am done with my consult that the nurse will run up, did you get the DNR? So sometimes I haven't gotten it at that first engagement, that first discussion, frequently. As a matter of fact, I try to enter these discussions without an agenda. Although what I tell my team, or I used to tell them, is that if we're being consulted, often there's an agenda. But I try to enter without an agenda. I try to start by, let's build a rapport. Let's see where are they coming from? Where are they at? What is their understanding of the situation? How far can we take the conversation? And then we tend to have a bias, and that is that we sort of already have an agenda about what we think they should do. But another one of my favorite little mottos is, it's not about me. I may not choose what they're choosing. I think it's important that they are well informed, that they know what all their options are. But I have to accept sometimes that they're going to do what they think is going to be best for them. Next. So I think it's important to kind of avoid things that would interrupt these engagements, to sit down and make eye contact. And some of the other questions that can be helpful is, now that you've had a chance to, hear about the situation, hear about the illness, maybe you had a consult with a specialist, what is important to you? What about the future concerns you? And then my question as to if there was anything I didn't ask that they want me to know. Next. So other approaches to sharing prognostic news. It can be hard to predict what will happen. I hope you will live a long time, but I'm worried about progression. I'm worried about side effects. I'm worried about maybe the intensity of the treatment. I might be worried that the time frame is kind of short. So next slide. Another thing that comes up frequently is this idea of the miracle. And I think that's important kind of to have a way of exploring that. And what they recommend is that actually we lean into the miracle. We want to go and get, and the first thing we want to do is we want to get more information. So we tend to, as physicians, we think, well, if we just give them those, we need to go over those lab values again, or we need to show them, we better show them this picture, these pictures, and they'll understand if we just bring them more data. This isn't about data. This isn't a knowledge deficit. And we don't want to get caught up into debating theology with folks, but we do want to understand a little bit more about what that means to them. So for some folks, that miracle might mean they will make it to the holidays, to Christmas, to the birth of a baby. Other people, the miracle would be complete and total recovery. But I think it's important to at least understand how, and then you might explore how long would it be appropriate to wait for a miracle? Would we know, how would we know if if that's going to happen or if it's not going to happen? Should we have a plan B just in case? So these are some of the things to kind of explore with miracles. Next. And then when I'm talking about code status versus allow a natural death. And that's one of the things that one of the first things I kind of, when I having this conversation, I tell people that when we are resuscitating someone, we are interrupting a natural death. And then I make sure we kind of understand that we can attempt a resuscitation. We may not be successful, which is why I like to use the expression of, would you want us to have an attempt at a resuscitation? Then we know that survival, and that would mean the person would be discharged is limited after inpatient CPR, between 6 to 15%. And a lot of people, I think, unfortunately, the media has given people the impression that, after a couple of thumps on the chest, a person just gets up and walks out. The challenge is that if we're doing CPR once, there's a good chance that it's going to be needed again. And the likelihood of full recovery is very low. And a lot of folks are surprised. They don't realize that. When we have people in particular who have a high symptom burden, multi-organ failure, or prolonged hospitalization, the likelihood of returning to their previous level of function is very low. And then I would make a recommendation based on that individual's circumstance. And sometimes we might talk about what would be an exit strategy or what would the end game look like. And a lot of times people have thought about what they want their, end to look like, what they want their death to look like. Next slide. So advanced directives. When we are talking about some of this language, some of the terms that we use for the person that would be the surrogate, your healthcare proxy or agent, or your power of attorney for medical decisions. And then on most forms, you usually can put down up to 3 people who could serve that role for you. The document also refers to, we call it the advanced directive. It can refer to the document, and that the advanced directive tends to be kind of generic. There's a place for you to put people that you would have act as the proxy or the agent. And then they might have something kind of generic, like, would you want to have your life prolonged or not? The challenge with it is not very specific. And I think the challenge is a lot of times families kind of aren't sure with that information. Oftentimes the medical world is much more complex than some of these sort of generic forms delineate. Next line. The POST, on the other hand, is actually an order. So it's an order that can be followed by medical personnel. It's more specific, specifically addressing code status, feeding tubes, and whether a person wanted comfort management, the selective management or full. So I tell people if they're opting for a full code, they're opting for full management. That includes the ICU. That includes, the whole ball of wax. So the POLST is the bright pink form, often recommended to have it on the refrigerator. So if the EMS team was called, they could see it and it would be easily obtainable. So I had to call 911 for my dad earlier this year. And the first thing I did was make sure that they had that POLST when they came, because it was on the refrigerator. And this is voluntary. We can't require people to fill out the forms. The advanced directive, on the other hand, is a more generic type of form. It's not an order. So people do bring them to the hospital, but it's not an order that the same way that the POLST is. Next. So who is appropriate for the POLST? The POLST is not intended for the general population. It is meant for people who have serious and life-limiting illness or frailty, those with advanced age. And for patients whom the medical professionals would not be surprised if they did have a limited time frame or if they were to pass within the next year. These are people at high risk of a medical crisis. So people were likely to be calling 911 on. It wasn't intended to be used in a general population, and it's not just so that we can get the code status down. Not all residents of a skilled facility are necessarily appropriate for a POLST. Next. So when we are working on the POLST, we want to make sure that the patient is well informed about their medical we want to make sure they are well informed about their medical situation. So they say the POLST is only as good as the conversation that preceded it. So it's not intended for us to just leave it with them and have them fill it out. It's about having a discussion about the medical situation, understanding what their priorities are for their care. What are those things that are important to them? What are those procedures that they would be worried about or that they might want to avoid? Do they understand the implications of being a full code? And then once these kind of dialogues have been had, then it's time to go ahead and fill the POLST out. It's important to make sure too that your patient has the capacity for understanding the decisions that we're asking of them. Next. So in summary, palliative care is specialized medical care for people living with serious illness, not just those with terminal illness. It focuses on addressing issues, symptom burden, the stress of illness, and our goal is to help improve their quality of life and help them to be well informed. It is provided by a specialty trained team of interdisciplinary team, physicians, nurses, social work, sometimes pharmacy, psychologist. It is based on the needs of the patient, considering their context with the family. It's not based just alone on the prognosis, and it is appropriate at any age and any stage of serious illness. Next slide. So palliative care also helps improve value. It reduces avoidable spending and utilization. It can reduce readmissions by 48% and cost by 28%. Outpatient services can also reduce our readmissions and the back and forth to the ER. Overall, estimates are reductions of about 36%. And improvement in symptoms, also substantial improvement in symptom distress. And folks in surveys demonstrate high satisfaction with palliative care, over 90%. Next slide. This is one of the resources that I find really helpful. It's Vital Talk. And what I like about Vital Talk is you can actually observe videos of providers having conversations with their actors, with patients, and you can pick up some communication techniques, kind of experiment, see what sort of fits or feels natural for you. Next slide. And then I have a whole list of other resources, and maybe we'll leave this slide up because the good news is there is a wide variety of good resources available to help folks and to get these conversations going. What about any questions? Are we doing okay time-wise?
Yes, we are. If anybody has questions, please unmute yourself.
Yeah, thank you, Dr. Schroll. That was a really interesting and informative talk. I kept thinking when you were talking about this about a situation I ran into in the emergency room. So I'm an ear, nose, and throat surgeon, and I got called in for this patient that had essentially advanced unresectable head and neck cancer, and she came in with a sentinel bleed. So basically she was having this bleeding. It stopped on its own, but usually in ENT, that's a sign that the end is relatively near and they may have a catastrophic bleed that essentially is going to be the end. So she's there in the emergency room with her doctor. I've never met this patient before. The patient can't hear. She has hearing aids, but she essentially just reads lips of her daughter. And even if I take my mask down, which I'm not supposed to, she can't really read my lips very well because she's never met me before. And essentially my job is to go in and see, do we have to do anything right now? But I feel like part of my responsibility was trying to figure out, what the plan is for this lady, because this is probably not the only time she's going to be at the ER. So I tried to have a little conversation with the daughter and the mom about kind of what her wishes are, and tell her about the severity of having this bleeding event. And, eventually I said, would you be open to a referral for palliative care if, we're able to work that out? Because I feel like that's part of the challenge too. The emergency room is kind of this no man's land of how we're going to get people in to see palliative care. And so I just felt like it was essentially the exact opposite of everything you recommended in a situation here. But I wonder if you had any tips of how I could have done better in that situation.
Well, I mean, it sounds like you had a pretty, good sense of, and I think probably handled it as well as could be handled in the environment. And the ER is definitely a place where where palliative care is just so critical. So I think the first thing is getting more of that information about what do they understand. So because I would occasionally go into the ER and see folks. It was kind of based on availability if we happen to have availability at that time. And so the first thing we kind of want to get that, okay, so what is their understanding? Who has been following? What discussions have already been had? It was kind of where, and so was she currently in oncological treatment or therapy?
She was being followed down. It was like Davis or UCSF or
somewhere
something
else.
like that. Yeah. And
Well,
so,
now I'll tell you what I often do in those circumstances is I recommend that they actually request a palliative because those institutions have that available. And I often have you had a chance to talk with the palliative team at UC San Francisco or Davis? Because I think sometimes in that environment where they're already, involved, I think it's appropriate to kind of maybe introduce some I'm really kind of worried about the possibility of this recurring, or I'm worried about what this is, what this means. Is that something that you want to talk about?
yeah, I did ask a little bit about that too. And the daughter said, oh yeah, somebody had brought it up once in the past, but she just wouldn't, like the mom wouldn't engage with them. So the actual patient wouldn't engage. And it's like, it's one of these things that, the treatment for advanced head and neck cancer, it's very invasive. We're talking about doing a trach, we're talking about doing major surgery.
It's intense.
Tying off arteries, and
yeah.
that can easily cause a stroke. And it's just like, we needed to get the information of what does this patient want, because it may very well come in an emergency situation where the default is we just do everything, which probably a lot of people don't really want.
Yeah, right. And then of course you've got the trauma to the family, because as soon as that's under that situation, then they're left making some of those decisions. And so sometimes I have told patients that the reason that we talk about these things is because sometimes they don't want to talk at all. And then I told them that for me, I have observed that it is so traumatic for families to make decisions when patients can't make those decisions for themselves. But of course, you had someone who also was having some hearing issues on top of.
Yeah.
Sometimes
I tried to see if I could,
it sounds like what that patient needed.
Mess.
Yeah, what that patient needed was a really extensive palliative care intervention, including interpretation. And I don't know if she was even able to, I don't know if she would be able to do sign language or anything, if she was.
Yeah, she didn't do sign language. It was just one of these people that has really bad hearing loss. And so they essentially rely on limited lip reading and just
work around it.
Already knowing what's going on. Yeah.
So then the whiteboard, then I bring out my whiteboard.
Mm-hmm.
Yeah. That's a tough one.
So I feel like palliative care, I'm really excited about the idea, but then I feel like when I try, it doesn't go the way I want it to.
I suspect that you actually probably did pretty well. And the fact that you are analyzing, you know what I mean? The fact that you're analyzing it tells me that you, it's a priority. Yeah.
Well, I definitely appreciate hearing your talk and learning about these resources too. And I think it would be great. I don't know what we're set up with at Enloe, but if we had something that, if a patient like this comes to the ER and part of the hardest thing, I had no rapport with this patient. I had never met her before.
That's definitely one of the biggest challenges.
Yeah, like if a patient like that comes into the emergency room, what sort of resources can we give them? Or is it something, if they have a primary care doctor, what kind of resources can we give their primary care doctor to have this conversation, since they already have a rapport with that patient?
Yeah, that's why I usually try to find out where they are established and see what those, the resources might be available to them at that, where they have a team, so to speak. Yeah, the ER was a place that I always wanted to kind of get in and spend a little bit more time, but because you have so many challenges, you see so many challenges, things there. Yeah, for sure.
Yeah, how would you, kind of on a different topic, how would you encourage people to have these discussions with the real understanding that there is a time limit? Because I mean, this was a patient I was going to see at the end of my clinic day. So I didn't have somewhere I had to run off to. I mean, I was on call, and I think I got interrupted by a page in the middle of it, because it's like I have to answer call when I'm on call.
Yeah.
So like what would you do to try to make this more accessible to people? Because these conversations do take a long time, and often multiple conversations.
That's where I think the team is really key. So having, and one of my goals has always been to do more training, so that what I would call more frontline staff, so your social workers, your nurses, that you have more frontline, so the physician can kind of do their part. And then maybe the nurse could come in and help them just kind of process what they just heard. But I think that's where a team of folks who have had more training in that arena can be really helpful. Yeah. Okay. Well, thank you.
I don't have questions, but thank you. It was great. I actually, this is all hard information to have to deal with, but listening is huge.
Yeah. No easy answers. And I think, the bottom line is that we just keep learning and, keep practicing and keep learning. And whenever, we had a situation that didn't go well, then we bring it back to the team, and we kind of like, okay, what did we learn from that situation? What would we do differently? Maybe I didn't read the room. I thought they were ready to hear this. Yeah, it's not easy.
All right, well, thank you. If there's no more questions, I'll wrap up and just remind everybody that we're recording this and it will be posted to the Butte-Glenn Medical Society YouTube channel. I'm happy to share that link. Thank you, Dr. Yee. And so, you know, and it's always probably a good refresher to just kind of hear this again, I'm sure, in the future.
And those resources, I recommend checking out some of those sites because there's some good stuff. Yeah. Thanks, everyone.
Yeah.
Thank you. Maybe we'll see you December 1st for COVID-19 and student athletes with some speakers from Stanford, thanks to Dr. Robertson.
Oh, interesting.
Mhm. The Medical Society does a lot of support for sports physicals. And we realized that we need to communicate with all of the primary care physicians in the facility, as well as our own volunteers, to prepare for screening of the student athletes.
Mm-hmm. Yeah.
All right, well, it was good to see you, Dr. Schroll. We'll talk soon. I'm gonna look up the CSU palliativecare.org website when I have a moment, because I know that wanting to support something happening in the future.
Yeah, there's so much need here in the North State. So fingers
And
crossed.
if the psychiatry residency gets off the ground, which I really do hope it does, there's definitely a part of this presentation that would be good for residents to hear, for sure.
I mean, communication skills, can use them in so many of our work.
I need them when talking to my teenagers.
You know what was really funny? I gave a discussion, and the woman who heads up medical staff, Kathy, she says to me, she goes, you know, that wish worry thing works really well with doctors. I wish that I could give you better news, but I'm afraid that this is, we're not going to get this, you know, whatever it was the doctor wanted. It was pretty funny. So she's using her techniques on them. I've got to check out. The phone's going.
All right, we'll talk to you all later. I'm going to stop sharing and stop recording.
Thank you, everybody. Thank you, Dr. Schroll.
Thank you.